When assessing a patient's aerobic capacity in a standing position, you want to reassess their vitals as soon as they start standing. When the vitals are okay, you can instruct the patient to do some mini squats. You want to instruct them to do about 10 or until they can tolerate, but we're looking for about 10, and then after we're going to have them do some heel raises. Once again, we're going to do about 10 or until she can tolerate. And we're going to also do some side bending with the same about 10 to each side or until the patient can tolerate. And lastly, we're going to do some trunk rotation. Just about 10 or until the patient can tolerate it. 10 to each side. We're going to repeat each exercise 10 times and then reassess the patient's vitals before proceeding to walking. Thank you. To assess ankle brachial index, you're going to first want to take blood pressure in the left arm, and also afterwards you're going to want to take blood pressure in the right arm and take whichever one is higher and write that down. Now I'm going to place my blood pressure cuff around my patient's right leg and locate the dorsalis pedis pulse. When I found the dorsalis pedis pulse, I'm going to apply some of the lubricant to this area and palpate it. Now I'm going to place my transducer over the pulse. I will hear a swish, and I will know I'm over the pulse when I hear that swish. I'm also going to inflate the blood pressure cuff to about 20 milliliters of mercury above the last audial pulse, and then slowly deflate the cuff at a rate of 1 millimeter per mercury per second until that pulse is audioable again. I'm going to take the highest systolic blood pressure value from the leg and to take that and divide it from the highest systolic blood pressure value in the arm. As this value is close to 1, I know that Katie has a normal ankle brachial index. To calculate my patient's blood pressure, what I'm going to do is place the distal end of the blood pressure cuff 1 inch above the antecubital fossa and then palpate the brachial artery. I'm going to make sure the artery is marking the arrow on the cuff when I wrap it around, and ensure the cuff is tightly around my patient's arm. I'm also going to make sure the valve is closed and place the stethoscope on the brachial artery. I'm going to inflate the cuff to about 20 to 30 degrees above what I believe the systolic blood pressure to be, and release the cuff about 2 to 3 millimeters of mercury per second. The first sound I hear is the systolic blood pressure, and when the sound disappears, that is the diastolic blood pressure. That is how you take someone's blood pressure. With peripheral lower extremity edema, you might want to take a calf girth measurement. Start by locating the tibial tuberosity. Now, measure about 10 centimeters down from the tibial tuberosity. I'm going to mark that spot, and I'm going to go to take my calf girth measurement at this spot. I got about 33 centimeters. Now that I have my calf girth measurement, I'm going to want to repeat this bilaterally. For the capillary refill test, what I'm going to do is I'm going to locate the great phalanx. I'm going to give it a good squeeze, and I'm going to time how long it takes for it to come back to that color. So I have the great phalanx right here. On its nail, I'm going to pinch a squeeze. It's going to turn a little bland, and then I'm going to time how long it takes to come back to its normal color. Normal time is less than 2 to 3 seconds, and with this toe, I'll show you one more time, it comes back almost instantly. So this is the capillary refill test for the great phalanx. To assess my patient's upper chest wall mobility, I'm going to place my hands on the upper chest around the level of the fourth rib with my hands on the external angle. I'm going to ask the patient to take a deep breath in and out, allowing my hands to move with the breath. I'm going to assess for anterior or inferior or superior or posterior rise in my hands. I'm also assessing for equal and adequate chest wall excursion bilaterally. To assess the middle chest wall mobility, I place my hands on the level of the xiphoid process and take up the slack. I'm also going to ask the patient to take a deep breath in and out, allowing my hands to move with the thumbs to separate. I'm going to assess for equal and adequate chest wall excursion bilaterally. To assess the excursion on the lower lobe, what I'm going to do is I'm going to put my hands on the patient's back around the 10th rib. And I'm going to take up the slack right here, and I'm going to instruct the patient to take a deep breath in, and out, and in, and out. So once again, what I'm assessing for is equal excursion through the opposite hands to see if my hands are moving up equally and moving down equally. When measuring my patient's upper lobe, I'm going to place the tape measure over the sternal angle, holding the tape measure taut. I'm going to ask the patient to take a deep breath in and out, allowing the tape measure to move and record the excursion that occurs. Normal excursion is 2.5 centimeters. To assess the excursion of the middle lobe and the lingula, what I'm going to do is I'm going to place the tape measure over the xiphoid process, holding the tape measure taut, and I'm going to ask the patient to take a deep breath in and exhale, allowing the tape to move and measure the excursion that occurs. The normal excursion for the middle lobe is about 3 to 4 centimeters, or also 1.5 inches. When assessing lower lobe chest wall excursion, I'm going to have my patient sit at the edge of the bed and place the tape measure midway between the xiphoid process and the umbilicus. Going to make sure the tape measure is taut and ask the patient to take a deep breath in and out, allowing the tape to measure to move. Going to measure the excursion that occurs. The normal excursion for the lower lobe is 4 to 5 centimeters, or 1.5 to 2 inches. When measuring my patient's heart rate and respiratory rate, I'm going to be seated right next to my patient and locate her radial pulse on the base of her thumb. I'm going to measure her pulse for 30 seconds and multiply that by 2. Without telling her, I'm going to count the number of times my patient's chest rises and falls for 30 seconds and also multiply that number by 2. That is assessing respiratory rate. For the normal adult heart rate is 60 to 120 beats per minute. The normal adult respiratory rate is 12 to 20 beats per minute. With Katie, I had about 62 beats per minute for her heart rate and 13 breaths per minute for her respiratory rate. Like the heart sounds, I'm going to put my earbuds and my stethoscope facing forward, and I'm going to use the bell of the stethoscope. I'm having my patient sit down, and I'm standing right next to them. So what I'm going to do is start out with the aortic. So start with find the second intercostal space right here, and go right, his right, which is right here, lateral. And I'm just be listening through the bell part of my stethoscope. What I'm listening for is abnormal heart sounds, or an extra heart sound, or a murmur. I'm also going to go to now the left second intercostal space. This is the pulmonic. And now I'm going to be moving down to the mitral valve. And last, I'm going to be moving to the tricuspid valve. When assessing a patient's lung sounds, I want to make sure my earbuds are facing forward, and I'm going to be using the diaphragm of the stethoscope. So what I'm going to do is I'm going to put the stethoscope on there. I'm going to instruct the patient to breathe in and out, and in, 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 and out. When listening to the posterior aspect of the lungs, you want to make sure that you're listening to the upper lobe above the level of T2. Breathe in, and out, and in, and out. And now, to measure the lower lobes, you want to make sure you're below T2. And in, and out, and in, and out, and in, and out. I'm assessing for any adventitious or abnormal breath sounds. The 2-minute walk test. And this purpose of this test is to assess the patient's aerobic capacity. First, I would take a patient's vitals when getting them standing. I would also measure at a distance of about 100 meters and then be spotting the patient the entire time. What I'm going to have the patient do is walk from cone to cone back and forth. Can I have you do that, please? Instruct to the patient that the object of this test is to walk as far as possible for 6 minutes. You'll have to walk back and forth for 6 minutes or as long as you can, so you'll be exerting yourself. You'll probably get out of breath or become exhausted. You're permitted to stop, slow down, or rest if necessary. You may lean against the wall when resting, but resume as soon as possible. Asking the patient how they're doing and their RPE. So, how does this feel right now? Are you okay?
This feels fine.
What would you rate it on a scale of 1 to 10?
1.
1? Okay.
All 1.
So, as the patient keeps going, I'm going to keep assessing how they're feeling through the scale using RPE, rate of perceived exertion. Once again, how are you feeling?
Feeling alright.
Feeling alright? On a scale of 1 to 10, what would you rate this?
All 1.
1 still. So this, I would continue doing this for about 2 minutes or until the patient is unable to continue. I would also reassess at the end with taking vitals.